Okay, so this lecture was about altered perfusion, so mostly talking about the heart and processes of delivering oxygen to the tissues. So perfusion, as we learned last week, is the process of supplying oxygen to the organ systems by forcing blood through a vessel into capillary beds. And perfusion is going to depend on a lot of these components. Again, don't really worry about these for the exam, just understand what perfusion is. Ventilation-perfusion matching. So in order for gas exchange to be effective, we want to move roughly the same amount of oxygen into the lungs that we move into the blood. Okay, and that's the idea of ventilation-perfusion matching. It's not a perfect process. The ratio is about 0.8 to 0.9. You don't need to worry about that number. Just understand that we want roughly the same amount of oxygen coming into the lungs as we pass into the blood. So circulation can be divided really into two main types of circulation. One being the pulmonary circulation, which is the circulation from the right side of the heart into the lungs. The systemic circulation, this is the left side of the heart moving blood into the system, to the tissues. And then the cardiac circulation, which is really just a part of the systemic circulation, is the blood flow to the heart muscle itself, the myocardium. So of course the heart contains four chambers, two atria and two ventricles. The left and right sides of the heart are separated by a septum, so the left and right sides normally don't talk to each other. Okay. As far as blood flow through the heart, we can review that really quickly here. So if we start in the right atrium, so the right atrium receives blood from the superior vena cava and the inferior vena cava, as well as the coronary sinus, which is bringing blood back from the heart muscle itself. So we're in the right atrium, and then we will flow through the tricuspid valve into the right ventricle. From the right ventricle, we go through the pulmonic valve into the pulmonary trunk, and then the left and right pulmonary arteries. Okay, and they go to the lungs, and then that oxygenated blood is brought back to the left atrium through the pulmonary veins. From the left atrium, we go through the bicuspid valve, also known as the mitral valve, into the left ventricle. From the left ventricle, we go through the aortic valve into the aorta. Ascending aorta, aortic arch, descending aorta, out to the body. So the cardiac cycle, this just refers to all of the events that occur in the heart during one heartbeat. And it's a really complex process, and there's a lot to it. We didn't really talk about it in any detail. Just a couple of terms here. Contraction of the heart or the heart chambers is known as systole. And then relaxation of the heart or heart chambers is known as diastole. This is just a little graphic showing all of these different events that occur in the cardiac cycle, and again, we didn't really talk about these in any detail. Alright, then we talked about the intrinsic conduction system of the heart, which is the way that the heart conducts impulses through itself in order to contract. And it all begins in the SA node, or the sinoatrial node. This is the heart's pacemaker, and it's called that because it depolarizes faster than any other component of the intrinsic conduction system of the heart. Okay, and the sinoatrial node is going to spread impulses across the atria, so it's going to stimulate depolarization of the atria and contraction of the atria, and it's also going to pass impulses to the atrioventricular node, or the AV node, down here. Okay, and the AV node, its big job is to delay the impulses from the SA node. Okay, so it receives these impulses, and it tells the impulses to slow down, and that allows the atria to continue or complete their contraction before the ventricles start to depolarize, because we do not want the atria and ventricles contracting at the same time, or else we wouldn't be pushing blood anywhere. So we want the atria to contract first and then the ventricles, and the AV node is very important for slowing those impulses. Now after the AV node, we send impulses into the AV bundle, or the bundle of His. And the big takeaway with the AV bundle is that this is the only electrical connection between the atria and the ventricles. Okay. Now from the AV bundle, we go to the left and right bundle branches, which we find in the interventricular septum, and they conduct these impulses down to the Purkinje fibers. And the Purkinje fibers are going to be responsible for depolarizing the ventricles. And those are the big takeaways that you should be familiar with. Okay, the electrocardiogram, EKG, or ECG. This is just a graphical representation of the electrical activity in the heart. There are three main events. There's the P wave, there's the QRS complex, and then there's the T wave. There's also sometimes a U wave, but the three big ones are P, QRS, and T. So the P wave, this is that first upward deflection here, and this indicates depolarization of the atria. Okay. The QRS complex, this is going to represent mostly ventricular depolarization. Atrial repolarization occurs at the same time, but you don't really see it because the electrical activity of ventricular depolarization is so great that you don't see the electrical activity from the repolarization of the atria. And then finally the T wave, this indicates repolarization of the ventricles. Okay, right here. So basically here we have atrial depolarization, ventricular depolarization, and then the T wave is ventricular repolarization. Alright, cardiac output. This is just the amount of blood pumped by each ventricle in 1 minute. Cardiac output is given by this equation, stroke volume times heart rate. So you need stroke volume and heart rate in order to calculate cardiac output. Stroke volume is the amount of blood pumped by one ventricle per heartbeat. Okay, so how much blood is pumped out per heartbeat. And then heart rate, of course, is the number of heartbeats per minute. Okay, you don't need to know about any of these numbers down here. The range of cardiac output can be anywhere from 3 to 9 liters per minute. It just depends. Just be familiar with the components of this equation and this equation itself. So blood pressure, this is just the force that's exerted on a vessel wall by blood within that vessel. We measure it in millimeters of mercury. And blood pressure really depends on 4 things. Contraction of the left ventricle, so strength of contraction or weakness of contraction. Peripheral vascular resistance, so if there's any resistance due to, diseases of the arteries like arteriosclerosis or atherosclerosis, that can increase resistance and thus increase pressure. By the same token, arterial elasticity, so our big arteries in the body are elastic and we want them to be elastic. It allows them to take a lot of force, but if they become more rigid, which happens in arteriosclerosis and atherosclerosis, then they can't expand as easily, and that increases blood pressure. Also the viscosity and volume of blood, so obviously if the blood is more viscous, which happens in the case of living at high altitudes or smoking, and same thing with the volume of blood. If the volume of blood increases, that's also going to increase pressure. And of course we know that things like the renin-angiotensin-aldosterone system greatly influence the volume of blood. Pulse pressure is just the systolic pressure minus the diastolic pressure. The systolic pressure represents the pressure, the blood pressure during systole when the heart's beating. And then the diastolic number, the bottom number, represents the pressure in the vessels when the heart's at rest, diastole. Okay, this is just showing those components that affect blood pressure. Same thing with diastole. So blood pressure regulation. We have a couple of quick acting ways, but the big takeaway with long-term blood pressure regulation is that it occurs by the kidneys. And we've talked about all of those mechanisms already. Okay, then we just talked about some situations of impaired circulation. Hemorrhage, of course, is the loss of blood through a vessel wall. This is typically due to trauma, but it can occur otherwise, like in very serious infections and things like that, you can have hemorrhage. Thrombosis, this refers to clot formation, okay? And not only clot formation, but a clot that stays in place, so a clot that's forming on a vessel wall. And thrombosis is really influenced by what's known as Virchow's triad. And these are 3 things that really enhance the formation of clots, or really precipitate the formation of clots. And basically these are damage to the blood vessel wall, excessive clotting, so if you have, hypercoagulability for some reason, and then finally alterations in blood flow. So if you have turbulent blood flow, which you would see in the case of aneurysms or atherosclerosis, that enhances the ability for clots to form. Now if that clot breaks free, it is called a thromboembolus. And the term embolus is really a general term for any material that is traveling in the circulation that shouldn't be there, and it can obstruct a vessel. So this could be things like thrombi once they break free, sometimes fat, sometimes air, sometimes amniotic fluid, a number of those things. You don't really need to know any of those, just be familiar with what these terms mean. Okay, a couple of other concepts. Arteriosclerosis refers to thickening and hardening of the arterial walls. Atherosclerosis is a really more advanced form of arteriosclerosis. This is where we have an accumulation of immune cells within the wall of the blood vessel, and this precipitates the formation of those plaques, the fatty plaques. And basically, atherosclerosis will begin with endothelial injury. So damage to the lining of the blood vessel. Things like smoking, things like hypertension, diabetes, obesity, all of those things can induce endothelial injury. Now, since you have injury, you're going to have inflammation. And macrophages are attracted to inflammation because they're immune cells. And what macrophages do is they produce free radicals. And this will further damage the vessel. And it also oxidizes LDL. And the job of LDL is trying to deliver cholesterol to the area to try to allow it to heal, try to protect it. But of course that can be problematic. Now macrophages will migrate into the wall of the vessel, and they will consume this LDL that was oxidized. And once they do that, they are called foam cells. Foam cells are a $10 word for atherosclerosis. And as these kind of accumulate, you get the formation of those characteristic fatty streaks. Okay, we talked about aneurysms. Aneurysms are just these outpocketings of a blood vessel wall, typically in reference to an artery. Aneurysms are only really dangerous until once they rupture. Okay, an aneurysm doesn't kill you, but a ruptured aneurysm can. Common places for these to form include, up in the carotid arteries or the abdominal aorta. Again, you don't need to worry about that. Just understand what an aneurysm is. Venous stasis, just what it sounds like. This is the stasis of blood in the venous system, so slow transit of blood in a vein. And a number of things promote venous stasis, like heart failure, specifically right-sided heart failure, varicose veins, prolonged bed rest, inactivity, things like that. Atherosclerosis, aneurysms, and venous stasis all promote the formation of thrombi. Okay, inadequate cardiac output, so septal defects in the septum between the left and right sides of the heart. This will allow commingling of oxygenated and deoxygenated blood, and this is not good. We don't want them to mingle. Again, this is normal. There's a septal defect between the left and right atria about 24 hours after birth, but that will close up and everything. But some of these other congenital defects in the septa will be repaired. Valvular defects. So especially of the mitral and aortic valves. Some of these defects include stenosis, where the valve is narrowed, or regurgitation, where you have retrograde flow back up into the previous area. So for example, if you had regurgitation at the mitral valve, when the left ventricle contracts, it's pushing blood back up into the left atrium, and of course that's not good. Cardiac dysrhythmias, these are just electrical disturbances that can alter the coordination between the atria and ventricles. These can be relatively minor, or they can be, severe. Like in the case of, ventricular fibrillation, that's not compatible with life. And then if you ever hear the term heart block, this just refers to obstruction of cardiac conduction, typically referring to the AV node, but it can really be anywhere. Sometimes they're unnoticeable, and sometimes, of course, they can be very dangerous. So here's just a couple of examples of septal defects. So this would result in regurgitation down here, and this is stenosis. Alright, then we started talking about the diseases, starting with hypertension. So this is consistent elevation of systemic arterial pressure over 140 millimeters of mercury systolic pressure, or over 90 millimeters of mercury diastolic pressure. Again, I believe that's lower now, but this is what the book had. There are really two main types of hypertension. There's primary and secondary. Primary hypertension is also known as essential hypertension and idiopathic hypertension. You should be able to associate all three of those as being the same thing. Okay, and this is by far the most common type of hypertension. Multifactorial, does not occur in response to another disease. Risk factors, of course, age, obesity, smoking, high intake of sodium or salt, insulin resistance, the list goes on. And then secondary hypertension, this occurs in response to another disease, such as kidney disease. So we talked about polycystic kidney disease and how those patients often present with hypertension because the pressure on the vessel stimulates the RAS system. Again, that's secondary hypertension because it's occurring secondary to another primary condition, like kidney disease. Clinical manifestations. So typically, early cases, you have no clinical manifestations. That's why it's sometimes called the silent killer. But chronic untreated hypertension can lead to clinical manifestations like heart disease, CNS dysfunction, headaches, problems with eyesight, kidney issues, the list goes on and on. Treatment, lifestyle modifications, medications, of course, so diuretics in order to decrease blood volume and therefore decrease blood pressure. ACE inhibitors, so if we inhibit ACE, we inhibit the conversion of angiotensin 1 to angiotensin 2. Angiotensin receptor blockers, so if we block those receptors, then angiotensin 2 can't do its job. And then beta blockers, which will act on the heart to try to kind of slow the heart and decrease its contractile strength. So this is just showing some of these classifications. Again, I believe this has changed now. As far as diagnosis, diagnosis should really be take an extended period of time, over a 3 to 6 month period, and not use isolated readings when it comes to diagnosing blood pressure. Alright, then we talked about heart attack or myocardial infarction, and basically this is the necrosis of cardiac myocytes due to extended interruption of blood flow to the myocardium or the heart muscle. Most commonly caused by atherosclerosis in the coronary arteries. So the coronary arteries, you remember, are the arteries that supply the heart muscle. All right. And atherosclerosis in those arteries is the primary cause of heart attacks. So the pathophysiology, basically these cardiac myocytes will begin to undergo apoptosis, which is programmed cell death, after about 20 minutes. And then if they do not have reestablished oxygen supply within that 20 minutes, they start to die. And when they start to die on a widespread scale, then we have necrosis. Now this necrosis, the death of these cells, will alter the conduction system of the heart, and this can cause possibly life-threatening dysrhythmias. Assuming the patient survives, those cells will be destroyed. They will kind of just degrade, and then proliferation of scar-forming cells known as fibroblasts will promote the formation of scars, okay, which is known as fibrosis. So clinical manifestations: sudden severe chest pain, crushing chest pain. Chest pain is known as angina pectoris. This pain may be referred. Also nausea, vomiting, sweating, dyspnea, sometimes a feeling of impending doom. But that's really more associated with other cardiac events. Complications, of course, sudden cardiac death. So if it's a very major blockage of a coronary artery, that can cause sudden cardiac death, and that's not good, obviously. So diagnosis, history exam, ECG findings, so being able to tell the difference between STEMI and non-STEMI heart attacks, and also increased troponin levels. So troponin is a protein found in muscle cells, so as those muscle cells start to break down, that troponin is released into the blood. So treatment, immediate administration of aspirin if it's available, antithrombotics, anticoagulants, PCI, which is percutaneous coronary intervention, which is basically the heart catheter. If that's unavailable, thrombolytics, though, for STEMI cases. We didn't talk about the difference between STEMI and non-STEMI heart attacks, so don't worry too much about that for this exam. Okay, and this is showing these are the coronary arteries. These are the vessels that supply the heart muscle. If you have a blockage up here or up here, that can be very dangerous because you are cutting off supply to a large portion of the heart. But if you have, an occlusion in a very small vessel supplying portions of the apex, you might be okay. And this is just showing some of these areas of necrotic tissue, very widespread necrosis occurring here. Alright, then we talked about CVAs, cerebrovascular accidents, also known as strokes. There's different ways to classify these. They can be ischemic or hemorrhagic, obstructive, thrombotic, embolic, which are ischemic types. Don't worry too much about that. Just realize that no matter what the cause is, there is decreased blood flow to the cerebrum, to the brain. Risk factors, a couple of big ones here: hypertension and smoking, but also diabetes mellitus, polycythemia, which is increased number of red blood cells, as well as AFib. And again, the problem with atrial fibrillation is if the atria are fibrillating, that allows blood to kind of settle and clot. And if you have this happening on the left side of the heart, that can drop into the left ventricle and then go to the brain. TIAs, transient ischemic attacks, these are mini strokes. They have very similar symptoms as strokes, but they're short-lived. They usually resolve within an hour. They have to resolve within 24 hours to be considered a TIA, and I always say that these serve as a possible warning. I always call these your get-out-of-jail-free card. So clinical manifestations of stroke. So we talked about the acronym FAST, which is face, so oftentimes unilateral, one side, face drooping. With that, you also have problems on that same side with the arms or legs or what have you. And even though I'm talking about the same side of the face, but the stroke is on the opposite side. So if you are having a stroke on the right side of your brain, you'll have manifestations on the opposite side, which is the contralateral side. Okay. Problems with speech, paresia, numbness, ataxia, dizziness. Again, it kind of depends, depending on the severity and location of the stroke, but those are some of the common clinical manifestations. All right, then we talked about heart failure. Simply put, heart failure is when the heart can no longer meet the demands of the body. Some risk factors: ischemic heart disease, so history of previous heart attacks as well as hypertension. But age, as age increases, obviously risk goes up for everything. Obesity, diabetes, renal failure, other problems with the heart, those are all risk factors. Heart failure can be classified a number of ways, but we're just going to talk about left-sided versus right-sided heart failure. And really, in most cases, right-sided heart failure is a result of left-sided heart failure, but they can occur independently. So let's talk about left-sided heart failure, which can also be called congestive heart failure. Congestive heart failure is sometimes used to just say as a term for heart failure in general, but it's really more appropriate for the left side. So basically, with left-sided heart failure, you have increased end diastolic volume. So this is also known as preload. This is basically the greatest volume of blood in the ventricle before it contracts. That's what end diastolic volume is. And what happens is, as that volume increases, it stretches the heart muscle. And I showed you the Frank Starling curve in class. And remember that once you get over that hill, once it stretches too much, the heart gets weaker and weaker and weaker. Once you get over the hill, that's heart failure. So that's what's happening here. We have too much volume. Volume's increasing, it's stretching the heart muscle, decreasing its efficiency in pumping. Now what happens, since we're on the left side, and you know that the left side of the heart is fed by the pulmonary veins, blood backs up into the pulmonary veins and the pulmonary capillaries. And what happens is this blood backs up in the lungs, so patients will have exertional dyspnea, so shortness of breath upon exertion, confusion, dizziness, orthostatic hypotension, which is hypotension, especially when standing up, decreased peripheral pulses and pulse pressure because of the weak heart, and as this condition continues, pulmonary edema occurs because that fluid's being pushed out of those pulmonary capillaries, and this will be worse when they're lying down. So at this point, since there is greater pressure now in that pulmonary circulation, the right ventricle has to pump harder. It has to push against this greater pressure in the pulmonary circulation, and this is where right-sided heart failure can set in. So the stressed right ventricle begins to enlarge. Again, as it stretches, that reduces its function. You might see tachycardia, cyanosis, decreased cardiac output, dyspnea, palpitation. But as blood pools on the right side of the heart, and remember, the right side of the heart is receiving blood from basically the system from the body. So as blood pools there, we have increased central venous pressure, and that's where you see the jugular vein distension. Okay. This increased central venous pressure is also going to cause distension of visceral veins, so veins of the abdomen, especially the hepatic portal vein. And this can cause congestion in the liver and decrease its function. Okay. Again, as this blood is backing up into the system, increased pressure in the capillaries will force fluid into the interstitial space, and that, of course, is going to promote edema, specifically pitting edema. And you'll see this in places like the lower extremities. So evaluation, diagnosis, based on history, clinical symptoms, ECG, echocardiogram. An echocardiogram is basically an ultrasound of the heart, lab test, chest x-rays, and then as far as also like a stress test, things like that. And then treatment, basically the goal is to increase the pumping efficiency of the heart and prevent further failure. So again, I showed you that Frank Starling curve, and even though once you're over the hill you can't go back, you can at least slow down your descent down that hill on the curve. So quick treatment, things like diuretics to remove excess fluid, decrease blood volume, and decrease the workload on the heart. Bed rest, O2 administration, digoxin, which is going to increase the contractile strength of the heart, vasodilators, compression stockings for the edema, and if somebody has pulmonary edema, this has to be treated because basically what happens is they're drowning. And this is just the comparison between right-sided heart failure and left-sided heart failure. Just to go back really quick with right-sided heart failure, even though the majority of cases of right-sided heart failure are due to left-sided heart failure, it can occur by itself. So, for example, since the right side of the heart is pumping blood to the lungs, any sort of lung disorders, things like stenosis of the pulmonary trunk, that increases the workload on the right side of the heart. That can cause right-sided heart failure. Sometimes chronic severe infections in the lungs can cause right-sided heart failure. And a term for basically right-sided heart failure due to diseases of the lungs, primary diseases of the lungs, is known as cor pulmonale. I just want to point that out because even though it is typically due to failure of the left ventricle or the left side of the heart, it can occur by itself. Okay. As always, if you have any questions, please let me know.